Well, thank you and good morning. Dr. Tadros covered a lot of the ARCH new graft technology yesterday in his talk, so I wanted to try and bring this one back in when I was unfortunately involved in the operating room yesterday. The good news for those of that were with us yesterday, we actually, once we got the left renal taken care of, she did very well with the SMA and right renal, and we did have to open one groin because she had a little groin flap, but she's awake, alert, doing well, moving everything, and advancing her diet, and will probably go home tomorrow. So thoracoabdominal, basically as has been outlined by several speakers, and especially when you do it in a collaborative way, I think gives us a lot of endovascular options now as we move forward, or hybrid options where you do some open and some endovascular. But I think we're seeing more and more options to do these in a minimally invasive way. But the question is, what's the long-term outcome from those? This is the classic real surgery with a thoracoabdominal from a type B dissection that had a ball valving over the orifice of the celiac SMA, and actually presented with mesenteric ischemia. But if you look at the data for patients with thoracoabdominal aneurysms from large series, as you've seen here, there is significant risk of complications for the thoracoabdominals, including paraplegia, renal insufficiency, and death. So if you've got a mortality, 30-day mortality rate in experienced centers of 8 to 10%, obviously that's something that is a significant concern, and other options need to be considered. So we now look at the endovascular thoracoabdominal. Dr. Tim Shooter was one of the early series looking at thoracoabdominal endovascular repair, which is basically relining the entire area of the thoracic and abdominal aorta that are aneurysmal. His original results were somewhat mixed in that he had 81 branches, 100% technical success. Hospital stay was still 11 days, which is significantly different than what we're seeing right now, where we can see and then generally go home in 2 days. Mortality of up to 9%, so not dissimilar from open repair. Paraplegia rate was still 4.5%, about half of what we were seeing with some of the open repair, but he was seeing a significant decrease in myocardial infarction, stroke, and renal failure, but still having endoleak complications also. So at least said that it's an opportunity to try and do something different with much lower overall morbidity and similar mortality. So we went and did a review of the Medicare database. I was fortunate while I was at Columbia, we actually had access to the entire Medicare database going back up to about 14 years. So we looked at any patient that had endovascular repair of a diagnosis for thoracoabdominal aneurysm or thoracic aneurysm with associated aortic aneurysm, and compared those to open repair of thoracoabdominal aneurysms. And here's the different codes we used within the Medicare database. We did a bivariate analysis of the demographics, population, comorbidities, and postoperative complications, and a lot of statistics were done. Kaplan-Meiers for both matched and unmatched variables, and then multivariate analysis. We also did something called propensity matching, where we looked at similar patients and compared their outcomes based on comorbidities. So what we're seeing is that there's overall trend to increase the use of endovascular repair. In the study we used up to 2011, and obviously that number has gone up almost logarithmically since that time, as we're finding more and more patients being treated endovascularly or with a hybrid repair. Going to Dr. Stewart's point also is that we're seeing that there's centers of excellence that are being created where patients are being referred specifically for repair of the thoracoabdominal aneurysms, especially the endovascular repair, and I think we're seeing better outcomes because of that. Here's the comparison we had just looking at patients with endovascular versus open repair. The demographics were very similar. The only difference, you had some patients that had a higher incidence of coronary disease in the endovascular group, as well as a higher incidence of cancer and diabetes. If you look at, we then matched those cohorts, so we got similar between the two groups. So now we had almost 1,000 patients with endovascular repair and 1,000 patients with open repair, and we could really compare those in a propensity score or match cohorts. 30-day complication, open repair for bleeding, respiratory failure, sepsis, need for tracheostomy, dialysis, all were much greater and statistically significant in the open group compared to the endovascular group. Device malfunction, yes, for an open repair, the device is fairly straightforward, but we're seeing they're getting more complicated now as they're going into descending thoracic aorta. And of course, there's always a greater incidence of emboli. But you can see the major life-changing high morbidity issues were all higher in the open group in this study compared to the endovascular group. Survival, initially for the first two, this is what we see in a lot of the aortic work. Mark Schermerhorn has done this for infrarenal aneurysms. I've done it for ruptured aneurysms. And we see that, the original survival is better for those patients who are going endovascular repair. By the time you get out to 2 to 3 years, if they survive that long, they tend to normalize back and have a similar mortality from cancer, myocardial disease, or other factors. Here's for these cohorts that are matched. Again, you see the same trend where those patients acutely doing better with the endovascular repair in regards to mortality, but then normalizing at about 2 years. So this is again showing the two curves being very similar at 2-year survival. And if you look at mortality by time points, again, a higher mortality in the open repair early on, 12 versus 8%. And then going out to 90 days, you're still a significant disadvantage in favor of the open repair in regards to mortality in the matched cohort. And then you start going out to the 2 years and then become normalized again. Complications, as we talked about, again, as they carry out over time and annual volume, basically those centers that do more do better. No surprise there. And again, I think we're going to see more and more, and we were discussing earlier today, is that in Europe we're seeing more and more centers of excellence being developed where people are being sent specifically to specific centers that do this. And I think we're going to see in the United States the same thing going on when you have the results that Dr. Stewart put forward. Why would you want to go somewhere that's only doing 1 or 2 a year? For open repair, again, you see that the annual volume matched is they are a distinct advantage as you go out longer in time. They do better and better for their complications. Long-term survival by procedure at best hospitals, we found that basically the results of endovascular repair and open repair were similar, but there still was an advantage for the endovascular repair. We can question it, but this was back when we looked at New York Presbyterian, Mass General, Cleveland Clinic, Texas, UCSF. So centers that did a lot of this work, we're seeing excellent results being done, but again, in centers of excellence. High volume center survival matched population. Again, you see the endovascular repair doing slightly better, but still good results in both. It's just really the mortality of these, or morbidity of these patients and the recovery time. Dr. Stewart alluded to the patients with connective tissue disorder, and I wanted to close with one of the cases of kind of a thoracoabdominal from the Marfan's patient population. Generally, I feel Marfan's patients should be treated with open repair because of the potential for degeneration, but many times what we find is we have Marfan's patients that come in that have already had a proximal repair and now presenting with a sequelae of their type B dissection that's become aneurysmal, as was this case. This is a 44-year-old woman at the time of her repair. She's now about 49, I believe, still doing well. She had a chronic type B dissection. Past surgically, she had open repair of a ruptured thoracic aneurysm and basically had no other major medical problems. Here you can see her dissection and her aneurysmal degeneration of her thoracic aorta. Extending down to the viscerals, you see celiac SMA coming off the true lumen, but the right renal tends to come off, or came off the false lumen, and then the left renal came off the true lumen with a septum or fenestration between the two. And then she dissection continued down to the aortic bifurcation, and she had iliac runoff bilaterally. We created a fenestrated graft for her to deal with a celiac, SMA, and left and right renal. Here we came in, we have the grafts going into the celiac and then down to the SMA, which all laid very nicely. The nice thing is that our cardiothoracic colleagues had given us this great Dacron graft to land the proximal aspect of our endograft in, so we knew we had good fixation there. We then came in from below and got the left renal through the other fenestration, and that allowed us access through the 3 of the 4 vessels coming off. The problem was the right renal. Here we came in, because of the septum there, we couldn't easily get through the fenestration within the septum, so we took an outback catheter, which has a needle that can be done. You can direct it to go in a specific area. We were able to then outback through the septum to get into the false lumen, dilate it up, and then able to engage the lumen of the renal artery through that septum and place our stent graft into that area. And here's the completion showing good perfusion of celiac SMA in both renal vessels, and then taking it down the iliacs. The dissection had gone down to here, and we did late come back in and put a little cuff down there to seal off that retrograde leak there. So in conclusion, I think endovascular repair for thoracoabdominal aneurysms is increasing in its level of acceptance, and we're seeing a significant decrease in morbidity and mortality as people are becoming more and more familiar with these repairs. And I think it really becomes a question of if you have a thoracoabdominal aneurysm, what type of repair would you prefer? A large open repair where the recovery will be at least 6 months when everything goes perfectly, or something in which you have 2 to 3 day recovery. I thank you for your attention and I look forward to your questions.